السلام عليكم ورحمة الله وبركاته. أنا دكتور أيمن البهلال، طبيب أسنان. تخرجت سنة 2008 من جامعة الملك سعود، بكالوريوس جراحة فم والأسنان. بعد كذا جلست سنة انترنشيب، سنتين جي بي، وبعد كذا قدمت على السعودي بورد فور اندودونكس وانقبلت الحمد لله. تنويه بسيط، I'd like to point out إنه التارجت الحين هم أطباء أسنان أو dental students, not the public، مو للعموم يعني. topic small clinical tips for greater success. أشياء تعلمتها من my mentors، من أخطائي، من كتب، من paper. But what I mean is some of what I'm going to talk about might work for some, might not work for others. Some are evidence-based. Of course, I'm not gonna cover everything in this field. And I'm gonna talk pretty much about most common cases, straightforward root canals. Let's face it, a lot of us get tempted by just making a diagnosis just from seeing an x-ray. That's wrong. So what you do is get your patient in, listen to him, ask him questions, do the tests, then find out which tooth is. Then you can proceed and take your x-ray. Molars, premolars, internal absorption. Most of the cases need more than an angle of very good x-ray. What I'm saying, there are some limitations, but you will have to deal with them. Shallow palate, gag reflex for the lower. Another thing many people are impressed when they see it is big preparations, big taper. It's not about that really, it's about recall and healing. Bottom line is the look of an x-ray is important, but there are many other things far more important. What's going on during the treatment. I had been looking for an x-ray to show you how to estimate the working length, whether you're using an apex locator or x-ray, but unfortunately after you make your diagnosis, you will open the tooth. It is very important to have a good design for the access cavity preparation. One of the most common causes of LH is having an inadequate access cavity preparation. Of course, in addition to that, inadequate access cavity preparation can result in separating files, stressing the files, unnecessarily missing canals. I highly recommend everyone to take a look at this article from the AAE about the law of symmetry in endodontics, okay? Information in this article will help you avoid mistakes, perforations, and locate canals predictably. Okay, I apologize. I have a patient right now, so I'll be back as soon as I finish, inshallah. So see you then. Most important things for the patient is pain, really. I just anesthetized my patient and try as hard as you can to make the procedure painless. Okay, I just finished one case and I think I found what I was looking for, the x-ray to show you how to estimate the working length. Okay, that wasn't really a very nice x-ray. Okay, the RCT is fine, but I'm gonna show you my point when an x-ray is not good. This is the premolar, okay? We see the buccal and lingual cusp are not aligned, are not on the same level. Compromise like this, what I do is draw a line here, not on the tip of the cusp, somewhere between the two cusps up to the apex, then minus 1 or 2 millimeters. Of course, I don't advocate this as your main tool to get your working length, but it helps a lot before using your apex locator, okay? Back to achieving a painless procedure, that is not only limited to local anesthesia and analgesics. There are very tiny things. One very important thing is when you place your clamp, Make sure it's fixed in place, stable. Don't make any chance for it to jump. How you do that? Put it on a sound tooth structure or root. Undermine tooth structure, it will fracture or the clamp will jump. This is made out of resin material. It is very helpful. When you're done with your procedure, just bring your Explorer and it will go away. Okay, done with your axes. You probably see or not see all the canals. Use a very sharp Explorer, look at the canals, then use size 10. Okay, this is how I did it. This is size 10. I used the tweezer, like we see here. Okay, tip. The maximum size you can pre-curve with K-files is size 20. Size 25, no pre-curve. Okay. I think I forgot to mention, there are some circumstances that you start your axis cavity without rubber dam, it's fine. For example, a crown or a tilted tooth you're afraid to perforate, then make your axis. Once you find the canals, place your rubber dam, you're okay. The instances I'd like to mention is having what appears to be a short fill. It is not necessarily wrong. What I mean, especially in lower molars, distal root, the apical foramen is located distally, not on the tip of the root. To mention also that is not exclusive for lower molars. It can apply virtually for any tooth. So your best bet is your apex locator. في شيء يضحك, don't get too focused with RCTs. Don't forget your posture. Now I'm drinking Solpadeine because of my back pain. Be careful. Anyone who's practicing endodontics is gonna break a file. Many files actually. There are guidelines to minimize the incidence of instrument fracture. They are all over the internet, books, articles everywhere. It's something I do whenever that happens. I never mention anything to the patient while I'm working. Don't panic, wait until you attempt to deal with it. And of course, it's not unethical or anything, it's just gonna complicate your procedure if you tell the patient, just do your thing, finish, then reassure. The fact is, having a broken file inside the root canal is not gonna affect the prognosis by any means, unless it blocks your way of cleaning the entire root canal system. I do also recommend reading a lot about the variables that can affect the prognosis of a separated instrument inside the root canal system, because that can affect the treatment plan. Okay, the elegant of choice. It's a chemomechanical preparation. Mechanical only is not enough. You have to use sodium hypochlorite. It is necessary. What I've seen a lot is many people are just using saline. That is not doing anything. You're not doing the patient any good. You have to use sodium hypochlorite. Okay, I'm not saying you don't use it at all. You can use it. You can use local anesthesia at the end of the procedure. You just flush the sodium hypochlorite, clean the canals. So when you're done with your instrumentation, you will flush the canals with saline, local anesthesia, distilled water, then dry the canals with paper points. So in conclusion of drying the canals, you might find, especially in infected cases, the tip of the paper point is slightly yellowish. If you could dry the canal in that case, wait 5 minutes. Put back the paper point, pull it, see if there is this color again, don't obturate. Exudate coming from the infection down there. So any moisture inside the canal is going to affect the quality of obturation. If that's the case, what do? Place calcium hydroxide, cotton pellet, cave it, wait 1 week, then bring him back and see what happens. The week after, when you flush the calcium hydroxide from the canals, you will most likely not find this exudate again, so you can obturate. Okay, I'm assuming most of you guys are doing lateral compaction technique, and that's what I use most of the time. I'm gonna show you something here. When you put your gutta-percha, you will have to have a tuck back. It is very critical in vertical compaction, less critical in lateral. What it means is the resistance when you try to pull the gutta-percha. The resistance you get when you try to pull the gutta-percha after instrumentation. Something I personally do is cut it at the level of the cusp with a scissor. It will be easier to insert your accessories. Always remember, the spreader has to go all the way to up to 0 to 2 millimeters from the working length. Okay, sealer. I don't have a mixed sealer now, but I use a lot of sealer during obturation. Avoid pumping, putting it to the working length and then putting back, because that can result in a massive amount of sealer buff beyond the apex, and you don't want to have that. So when I soak the apical third of the master cone with the sealer, I put it slowly in the canal circumferentially, slowly, not to the working length, then I pull it back. Then when I pull this master cone, I take a look at it. If there is an area of sealer wiped out, I apply a sealer again. Same way I mentioned previously, circumferentially, slowly to the working length, then cut the coronal tip, then I insert the spreader. بس في فيديو missing على موضوع الايزوليشن. انا تكلمت اللي اقصد اللي it will help you is the liquid dam اللي يستخدم للبليتشنج. Okay, so you placed your master cone, the spreader, then removed it. The accessory, I'm gonna talk about it now. The first accessory, take a small amount of sealer on the tip, measure it to the length where the spreader stopped. Then insert it there. If it stops there, you're okay. If it doesn't, if it goes longer, then you're probably gonna have an overextended accessory. Okay, and if it goes shorter than that, then you'll have a gap of the space created by the spreader. So repeat the whole thing again, the spreader and the accessory. And keep doing that until the spreader can no longer be inserted into the canal. Okay, I have received a lot of messages asking me to speak Arabic. I expect all of you are dentists, so you should be understanding what I'm talking about. Now you're done with your obturation. You need to clean the chamber. Everything, gutta-percha and sealer. Nothing should be there. Do that, of course, with heat, System B or a heated plugger. The rest you can use an alcohol swab. Some might say alcohol is a liquid. Yeah, it is a liquid. It is an organic solvent, but it will evaporate. It will clean the sealer well. Suppose you're doing 1 or 2 visits, you're placing a cotton pellet. Please pack it really well there, inside the chamber. Many practitioners just take a big piece of cavit, then place it, and ask the patient to bite. That's lousy practice. What I do when I use cavit is I place it actually in increments and pack it really well. That will keep it there. So when I do that, and if it happens and the filling falls, only the coronal part is gonna be out. It's gonna be sealed. However, if you're unsure when the final restoration is gonna be done, please use something stronger like GIC. One thing I do sometimes is I put a layer of cavit, then resin modified glass enamel on top of it. This way the restorative dentist or the prosthodontist, when they're removing the temporary, they know exactly when to stop when they see the cavity. Okay, for the post-operative care, try to slightly lower the expectation of your patient. An example of that is to inform your patient that they might have a mild to moderate amount of pain post-operatively that will respond to analgesics. So now I'm gonna be talking about the painkillers I prescribe post-operatively. So the first option would be ibuprofen between 400 to 600 milligrams 3 times a day with meals. So 1.5 hours after the ibuprofen dose, if no adequate relief is achieved, they can add 2 capsules of solpadeine. Solpadeine contains paracetamol 500 milligrams per capsule plus 60 milligrams caffeine and codeine 8 milligrams. Studies have shown that combining the 3 compounds together is superior to doubling the dose of one of them alone. And of course, lower incidence of side effects of each one of them. Now I conclude my presentation, or whatever you call it. I'd like to thank each one of you for watching. And of course, big thanks to Indo Edu Group for having me. I really enjoyed every single moment of this.